Thank you. So, as Dean Finnegan said, I'm Shalini Kulasingam. I'm in the Division of Epidemiology and Community Health, and today I'm going to be talking to you about the human papillomavirus, or HPV vaccine. HPV is a sexually transmitted virus that causes cancer and genital warts. Genital warts are cauliflower-like growths that occur in the genital region. So despite this pretty picture of the virus, this is one of the bad guys. In 2001, I was working on my dissertation with Professor Laura Kautsky from the University of Washington. Laura at the time was a principal investigator of a study that was looking at whether the vaccine could prevent disease in vaccinated women. She called me into her office, told me to close the door, and said, "Shalini, I just received the results from the study, and guess what? There was no disease in the vaccinated woman." And my response wasn't, "Wow, this is amazing." My response was, "Oh my gosh, my career is over and it hasn't even started." So right after that, I moved to Duke University because I wanted to learn about simulation modeling. And this is my first postdoctoral paper, and it was simulating the impact that this vaccine would have on a US population of women that had been vaccinated against HPV. But the thing that I want you to note, and these were unofficial estimates coming out of the CDC before the vaccine had been approved, was that approximately 70% of eligible girls would be vaccinated when this vaccine became available. A couple of years after that, I was approached by a small company in Australia that held one of the 4 patents on this vaccine, and they said, "Shalini, can you work with us to put in a submission to the Australian government so that this vaccine can be approved?" So over the course of a year and a half, I did just that. We submitted it to the Australian government, and as a result, Australia was the first country in the world to approve the vaccine. Shortly thereafter, the US approved the vaccine. Which brings me to my question: how are we doing compared to the Australians? And the short answer is, we're not doing that well. So why is that? Well, one thing, to keep in mind is that Australia's HPV vaccination is national, and it's also school-based. That means any adolescent attending school is offered this vaccine. What that also means is that very early on, after this vaccine was approved, they achieved high vaccine coverage. 80% of their eligible population was vaccinated. And if you look at the current numbers coming out of Australia, they have achieved a 90% reduction in warts, a 50% reduction in cervical precancer, and in the coming decade, they are expected to achieve significant reductions in their HPV-related cancers. So what about us? Well, what about us? So our coverage is at 60%, but that's right now. When this vaccine was initially approved, it was only at about 30% in girls. And this is what you see nationwide, but look at what's going on between states, right? So we have varying coverage, and the thing to note is that Minnesota, in this case, is in fact below average, which is something that I think for all of you, because we're used to being above average, it's like, what? So what are some of the reasons for this? Well, one is, this was initially marketed as a vaccine that prevents a sexually transmitted infection. And there's one thing that I really think is true about our country, which is that we are prudes when it comes to sex. Stormy Daniels aside, we just have a real big issue talking about sex. So what's the other thing? Well, this is a vaccine that has had a lot of negative press in terms of its safety profile. And this is despite a body of evidence that suggests quite the contrary. So where do we go from here? Well, one thing that we know is that there is a strong evidence base that shows that if we can empower clinicians to talk about this vaccine, that a clinician recommendation is something that parents, even vaccine-hesitant parents, will listen to. So we need to work with clinicians in order to make them feel comfortable talking about this vaccine. The next thing is, we need to change the narrative on this vaccine. This isn't a vaccine that prevents an STI, this is a vaccine that prevents cancer. Which parent is going to say no to preventing cancer in their kid? And I want to point this out because this is a campaign that the American Cancer Society is going to launch in June, and we're actually working with them. And as you note, HPV vaccine is cancer prevention. Last but not least, we know this in public health. We have to collaborate. And these are some of the groups that are collaborating nationally and locally in order to increase HPV vaccination. So what I can tell you is, over 15 years ago, I thought my career was over before it had even started. But what I can tell you, quite frankly, is that in the coming decade, if someone were to tell me, Shalini, it's time to move on, I would be more than happy to do so. Thank you.